Yes.
Yes,
please.
So good evening, everybody. Thank you again for participating hangout session of the vaccinology course MOOC of Institut Pasteur. I hope you enjoyed this week, the lectures of this week, which was the last week. So get ready to prepare the exam, because I think you have only a few days to finish that. So we are lucky today to have several lecturers on board for this hangout session. We have Dr. Flor Munoz from the Baylor College of Medicine in Texas, and we have Mark Doherty from GSK, and we are supposed to have also Guido Grandi, former Novartis researcher, and I think we can start with the question that have been selected by GB. Thanks, GB, for organizing these sessions for us.
Yes. Hi. I trying to screen the question to your field. So maybe I will start with the maternal immunization question for Dr. Munoz. It's been shown that the question is asking, it's been shown that maternal immunization with the ACP vaccine elicit antibodies in the newborn. But do we have any evidence of protective effect of these antibodies?
Yes, thank you so much for that question. And indeed, we have, as you know, an adult vaccine for pertussis. So ACP is a cellular pertussis vaccine, and this is the one that we can administer to adolescents and adults. And because of that availability, we have now several studies, at least one placebo-controlled randomized clinical trial in the United States, and other studies prospectively conducted in other parts of the world, including Europe and Asia, where a cellular pertussis vaccine has been given to women in the second or third trimester of gestation. And as mentioned, definitely you do have a very good response in the mothers and transmission of antibody to the infant, where we have a very clear evidence of higher concentration of antibody in the infants for several months, at least the first 2 months of life with certainty, which is the time when they start receiving their own vaccine. So the expectation is that during those 2 months, these babies will be protected. The only efficacy data that is available right now, which there is, comes from the UK. And in the UK, this practice of vaccinating pregnant women has been in place since 2012, and that has allowed them to do surveillance. And there are a couple of publications at this time available that demonstrate that doing surveillance of pertussis in the neonatal period and the first few months of life, you do have a protective effect with an efficacy that is very similar to the vaccination itself. So it's up to a 90% efficacy in protection of the baby, 90, depending on the time when the mother receives the vaccine. Unfortunately, if the mom receives the vaccine and the delivery happens in the 2 weeks after that, there is really no efficacy. So it's important to receive it late second trimester or early third trimester to be able to have that protective effect.
And also there's another question that they were wondering that if pertussis is only pediatric disease, or adult can get infected with the pertussis as well?
Again, very important concept, because we used to think that pertussis was for children only. This was in the 1940s. As a matter of fact, we know that pertussis affects ages. And we know that there is a cycle of the occurrence of pertussis, no matter where you are in the world, that about every 4 to 5 years we have outbreaks, so epidemics of pertussis that happen because the population immunity, so if individuals lose that immunity from having had either pertussis themselves or having had a vaccination effect. And so those outbreaks result in a reimmunization, if you will, of individuals, and then we don't see pertussis for some time. So what we know about this is that because we have better tools for testing. For example, we do PCR testing, and we know that pertussis presents differently in different ages, but we have now tested adolescents, adults, people of all ages that present with persistent cough, and that is pertussis. So as a matter of fact, because we vaccinate young children, pertussis is now more common in adolescents and adults, particularly if they are not vaccinated. And this is why we have now a vaccine recommendation for adolescents to receive a booster, because the high incidence of pertussis infection and disease was occurring in the teenagers. And then we have also a recommendation, at least in the United States, to vaccinate all adults, not just the pregnant women, because we know that even though they might not be deadly ill as newborns will be, they still have pertussis infection that then gets transmitted to others who are susceptible. So people in the extremes of ages, older adults and the very young, are the ones who do have the more severe consequences of pertussis, but it is definitely not just a pediatric disease. It's an infection and a disease that can happen to people of all ages, adults of all ages as well.
So we should all get.
I have a question. I have a question for Flor on that subject. What do you know about the recommendation in Africa? Is there any distribution of any pertussis vaccines except from the DTP? And are there any boosts recommended or not? Now, I'm asking that because I know that we have something like 500 to 600 African people looking to that MOOC. So they should be interested in that question.
Yes, it is a very important question because, as you know, the value or the effect of maternal vaccination is going to be different in different countries. What we have seen is that in many countries, which is probably the case in Africa, where children continue to receive the whole cell pertussis vaccine, DTP, right? There is actually a longer duration of protection for those children, so that they are protected in adolescence and they are even protected as they're older, better than in countries where we have started to use the acellular pertussis usually since the 1990s. So those people who receive acellular pertussis are now young adults, and that's why we're seeing also some of these cases of pertussis in the adults. So it's a different epidemiology, and it's a different context of problems. Now, the implementation or the use of the acellular vaccine in adolescents and adults, I'm sure is different in different countries because, again, it's not necessarily covered under the vaccination programs which focus on the young children, right? And there might be a different utilization depending on whether it's a private practice versus the public health system. But in general, I do not believe that it's used as widely as it is, say, in the United States or in some countries in Europe. And I have to say, even in these countries where we have recommendations since 2006 for adolescent vaccine, and then again 2012 for the maternal, the uptake is not 100%, right? So at best, we have about 30% of adults or so that receive the vaccine in the United States, maybe better in the UK, about 60%. And the main question that will remain is if it's necessary in Africa and in other countries that utilize the whole cell vaccine to actually do this adult vaccination and the maternal vaccination, will it add any benefit to already having childhood vaccines? I suspect that if we still see neonatal pertussis in these countries, and the incidence is not very high, but it happens, it's a matter of priorities. But there are studies ongoing right now looking at maternal acellular vaccination followed by infant whole cell vaccination to make sure that there's also ongoing protection and that there's no interference with the infant response to the vaccine.
Okay.
If that answers your question.
Thank you, thank you. We could discuss that longer, particularly in comparing the different type of vaccines in the different countries. We don't have time for that now. We'll discuss that later in Paris. Thank you, Flora.
Absolutely. Jibi, we can't hear you.
Yeah, we can't hear you, GB.
Looks like you're muted.
No, we can't. You can come here. What happens?
I have a problem with my
Oh,
computer.
please close the door. Close the door.
I
So she has to sit. She has to sit with me. In fact, we are
I have
in
a
the same
problem
room.
with my computer,
So
and
what happening?
I was trying to get a video to get online, but
This is because of
yes, and I
So let's go.
there's something going on. Okay, but okay. So the next question, maybe we'll try to ask Mark. And they say the study was shown in the lecture that the subject was tested for in a phase 3 clinical trial for HPV vaccine. Are they pre-exposure to vaccine for the outcome of the disease, infection of the HPV?
GB, Mark is also muted. We can't hear him.
Oh,
Yes.
Okay.
Mark, we can't hear you.
okay.
Please.
okay. Can you hear me now?
Yeah,
Yes.
no, you can.
Okay, I'll go back
Okay.
to
Go back to yours.
All right. So there have actually
Yeah,
been
please.
a number of phase 3 studies. The initial studies and the largest studies, like Future 2 and Patricia, screened all of the women for HPV using DNA, so using PCR screening and also using serology, with the goal of having a naive population as a baseline. And then they were rescreened during the course of the study, 7.5, 9.5 years for the two studies. And so they were looking, the primary outcome was lesions. So they were looking for cell alterations which can become precancerous. But as a secondary clinical output or a secondary endpoint, they also used infection, both by serology and by DNA. And in particular, they used what's called a 6-month persistent infection. So in other words, a woman who was positive at 2 time points with the same strain, which indicated that there was a persistent infection, because persistent infection is what's the risk for subsequent development of cancer. And the results were a decrease both in cell changes, in lesions, which could become precancerous, but also a decrease in 6-month persistent infections. So I think the evidence is good that we're seeing both of those effects there, that we're seeing reduced infection and we're seeing reduced persistent infection, which can lead to cell changes. Does that answer the question?
Well, yeah. I suppose. Still problem?
My computer just broke and I cannot control anything. But okay, I think that I hear that, yes, does you answer the question. Also, there's another question asking about the side effect of the vaccine. Do we know this any particular cause that of the side effect, or is it just case by case basis?
We don't know at the moment what the cause is, and we don't even have any good evidence at this point that the side effects are related to vaccination. So this is a hot political topic, so it might be good to give a little bit of background here. There have been a lot of reports of side effects coming primarily from 2 countries. So from Japan and also from Denmark. And I was actually in Denmark at the time that this controversy started and have talked to some of the scientists involved. So the reason it's difficult to say very much about the side effects is because the reports from the 2 countries are quite different. In Japan, where the issue started first, the commonest side effect which was reported after vaccination is what's called complex regional pain syndrome, where a person feels pain, usually in a limb. It could be a leg, it could be an arm, even a hand or a finger. And the usual cause of that is some kind of nerve damage. So the commonest cause for complex regional pain syndrome, for example, is actually falls. But it can happen if somebody cuts their finger or they're cutting vegetables in the kitchen. Any kind of trauma can potentially relate to that. And it's possible, for example, that if a nerve was damaged by a needle at the time that somebody is injected, that you could develop a complex regional pain syndrome. It's quite a rare phenomenon, and it's also difficult to attribute a specific cause because it can happen weeks or months after the trauma which caused the injury. And in Denmark, what was commonly presented was a syndrome which is called POTS. It's short for postural orthostatic tachycardial syndrome. And there, the effect is dizziness or faintness if a person stands up or engages in physical activity. So it's quite a different syndrome from what was reported in Japan. So that's a little bit hard to reconcile why the same vaccine would cause two completely different syndromes. But the second thing which happened is that both of these syndromes are quite hard to diagnose and may persist for some time. So working out whether there's a cause and effect with the vaccine has proved very difficult. So in Denmark, at least, there were a lot of cases. Most of these cases have now been to the evaluation board, which assesses for whether there is a vaccine-related event and which pays compensation. Almost all of the cases have actually been dismissed as unrelated to the vaccine. The last time I checked, 96 out of 104 had been rejected, and the commonest reason for rejecting them was were already existing before vaccination. And so I think that, so I was going to say it's a complicated point because we have, if you like, what we call temporal association. So POTS, the tachycardial syndrome, commonly occurs, it can occur in people of all ages, but it most commonly occurs in people around early adolescence. So 13 to 15 years of age is the common stage of onset. And it's a syndrome which, for some reason, is found mostly in girls. And of course, with HPV vaccination, we give the vaccine in the window 13 to 15 years of age, and we give it in most countries only to girls. So I talked to the scientist at the Frederiksberg Syncope Center, Louise Brint, who first identified this as a possible risk. And she said in Denmark, we've actually been seeing an increase in the tachycardial syndrome in POTS. But the increase started some years before the vaccination program did. So at this point, I would say it's a complicated issue. We don't know for sure if there's any connection at all. And untangling it is going to take some time. So right now, I would say the European Medicines Agency and the FDA in the US has commented on this as well, that there's no evidence of a connection, but there are still ongoing studies and ongoing follow-up in this area.
Okay. And I also have another question. That the now that they extend HPV vaccine to boys as well, is this because they want to control the infection, or there's a chance of boy to get cervical cancer? I don't. It was interesting.
There is no chance that boys will get cervical cancer, but boys can get HPV infection. And they can give it to their partners, whether those partners are boys or other boys or girls. So there are a number of different reasons for recommending HPV vaccination to boys. One of them is that boys can develop HPV-related diseases as well. So HPV is associated also not just with cervical cancer, but with anal cancer, with penile cancer, and with mouth and throat cancers as well. And again, this is a complicated issue. Cervical cancer is much more common than any of those other cancers. So the initial deployment of the vaccine focused on girls because cervical cancer makes up about 90% of the disease burden. But there are many doctors and public health officials who say, okay, that's 90% of the disease burden, but we shouldn't ignore the other 10%. So that's one argument for HPV vaccination of boys. In Scandinavia, where the issue was discussed a lot, the political and public health issue, there was also the question of what you call health equity. Is it fair to offer a treatment only to girls when it's possible that boys could benefit as well? So that's more of a social question than a purely medical one. And the flip side of the argument is we have good clinical trial data which shows that the HPV vaccine prevents the precancerous stages of cervical cancer, but we don't have any evidence which suggests that it prevents mouth, nose, or throat cancer or anal cancer. So at this point, you can say there are arguments for and there are arguments against HPV vaccination of boys, and I don't think the issue is going to be fully solved until we start getting better data on whether the vaccine is actually effective against these other cancer types. That's going to be very difficult for mouth, nose, and throat cancers related to HPV because they typically develop in people who are in their 60s and 70s. So 50 years after vaccination. We don't know if the vaccine will provide protection for that long. It's roughly triple the length of time that you typically see cervical cancers developing. There may be a better chance of seeing efficacy against cell changes which may lead to anal cancer because that tends to develop on a more rapid timescale. So this is really an issue which in many ways is more related to social equity and to public health policy than to hard science at this stage.
Okay, great. Thank you, Mark. We're going to switch gear a little bit from HPV vaccine to RSV vaccine. So maybe this question, Flo, you can help answer this question. They want to know that maternal immunization of RSV vaccine as maternal antibody will decrease up to 6 months, and then severe case of RSV can affect infant up to 2 years of age. And how do we tackle this issue? And is there any more development on the RSV vaccine for infants?
So yes, you have two aspects there, one related to maternal vaccines and the other to infant vaccine. And I have to tell you, this effort in having an RSV vaccine for pregnant women is actually at the very top of the priorities in terms of development of vaccines for maternal immunization. The reason is because we have a high impact of disease in infants in the first year of life, and as has been mentioned, up to the 2nd year of life. And we do not have a vaccine yet that can be given to children, especially the very young ones. And we do not have a good treatment that can be given to infants either that have RSV infection and disease. We have a number of antivirals that have been tested and used and even licensed in the past, but there are many barriers to their use in the sense that we still are understanding more of the pathogenesis of RSV and the effect of the virus versus the effect of the inflammatory response and the host response to the virus having probably a more significant effect. So the bottom line is there is a very high burden of RSV disease, and this is throughout the world. There's data from the developed world and also low middle income countries where you see that RSV is prominent in terms of respiratory infections in early life, and that it affects all children, not just say prematures. Actually, most of the babies that we see with RSV are full-term babies that when they get RSV develop lower respiratory tract disease and have multiple consequences immediately, including death, and potentially long-term, because there's a concern that having RSV in early life can also result in persistent wheezing or even the development of asthma in the future. So there's a lot of interest in that aspect. We also know that women who have antibodies to RSV, usually because, just like with pertussis, as adults, we also can get RSV. And we don't have an immunity that is very long lasting, and it's an infection that can happen more than once in our lifetime. But again, we don't get very sick as we are older. It's just the younger children that get sick, the infants. But in any case, there is good data showing that if you have maternal antibody to RSV that is transferred to the fetus in utero, and then the babies are born with higher concentrations of RSV, usually neutralizing antibody, but also binding antibody, that those babies do not get RSV very early. So there is a delay in the first infection when the moms have enough antibody that can transfer to the baby. And also there's data showing that these babies, even if they might get infected, they're not as severely affected as those whose mothers don't have enough antibody to transfer to them. So that's one proof of concept, if you will, showing that it should work, that you give maternal vaccine to induce antibody, because there's natural epidemiology, natural history data that shows that. The second proof is that you also have information from passive antibody administration to infants. And this is done through, in the past, RSV-specific immunoglobulin, and now monoclonal antibodies to RSV that can be given to high-risk patients, high-risk babies. So in this case, prematures or babies that have heart and lung disease, that can be shown and as actually in practice, because we know that it protects them from RSV infection and also severe disease. So to address the question about what is happening, there are actually multiple stakeholders, from manufacturers of vaccine to funders, to regulatory bodies throughout the world that are very interested in having a vaccine for RSV that is given to pregnant women, with the entire concept being we will boost those antibodies in mothers. We all probably have had RSV already in our lifetime, so it's just a matter of increasing the antibodies enough so that those babies are then protected by having that higher concentration for the most important time. In this case, might be the first 6 months of life, hopefully a little bit longer, but we know that maternal antibody is good for maybe 2 to 6 months. There are actually vaccines in all phases of development, and usually for maternal vaccines, we want a non-live vaccine. So that is an important distinction. And we have vaccines that are entering phase 2, so going into pregnant women and testing for immunogenicity, safety, and the concept that, again, you have transfer of antibody. And we have at least one vaccine that is currently on a phase 3 trial that is a global trial, enrolling over 8,000 mothers looking for efficacy. And this is happening in the US, in Europe, in South Africa. There are sites in Asia and Australia as well, and in South America. So it is a global effort, because we know that there is a potential benefit in all parts of the world. So that is for maternal vaccination. And we understand that there might be limitations. For example, depending on the time the vaccine is given, the babies might not be protected if they're born prematurely. So we still need other efforts or other interventions, such as still protecting the baby through passive antibody if they're born prematurely. And we also know that if we really want to have an impact on RSV disease in the first 2 years of life, we actually do need a infant vaccine, so a pediatric vaccine. And in this case, there's also a significant interest for development of this vaccine. There is a little bit more flexibility in that one is able to potentially use live vaccines, and there's been a lot of work for the last 30 years on developing live vaccines for RSV that are given through the nose to these babies. But again, those studies are also in progress, and as far as we know, there is work still being going in terms of different types of vaccines and phase 2 clinical trials, and soon to enter phase 3 clinical trials for infants as well. So it's a long answer, I'm sorry, but it is a very important topic at this time in the development of protection against RSV. And Jimmy, you are.
Yes, I got it. Oh, finally. Okay. Yes. But I left the question to Fred. I'm sorry.
Yeah, very shortly, Flor, but there is some noise about here. There was a question, and this is interesting. Antibody-dependent enhancement has been shown for RSV with the former inactivated vaccine. Could you very rapidly, shortly, precise how we are sure now that we will be really out of this problem? Because if you deliver antibodies from the mother to the baby, and that these antibodies might be able to make enhancement of infection, that would be a big problem. I suppose that we would have the answer in the efficacy trials result. But do we know something from the phase 2 trials already on that aspect?
Absolutely. So I will try to be brief because this is definitely a topic that deserves a lot of discussion and has had a lot of discussion. But as you mentioned, the concern about more severe disease in RSV vaccinated infants. So this was not a vaccine given to the mothers. It was a vaccine given to the infants. And actually, it was a very specific vaccine, a formalin inactivated vaccine, which is completely different from the vaccines that are being produced now. So one important point is that the vaccines that are being developed are distinct, clearly distinct, and not as similar at all to the vaccine that caused that problem in the 1960s. The second issue is that we are really not doing anything other than boosting antibodies in the mother. And the effect of enhanced disease is not considered to be mediated by maternal antibody. So that physiologically, biologically, there is really no grounds or no basis to be concerned of worsening a disease in the infants. And again, we have proof of concept with that, and the fact that natural antibodies don't do that, and that even passive antibody administration to the babies doesn't do that. So it has been discussed at many levels. The concern is minimal to none. However, I will say that all the studies, phase 2, phase 3 studies, are looking at this particular outcome. So we do follow those babies for their first and even their second RSV season to determine if they do have any problems with how they handle their RSV infection. But it's a very different concern that does not really affect maternal immunization, as opposed to when you do vaccinate infants. It may be something that will still be ascertained and very closely followed when infant vaccines are given.
Great.
Yeah, okay, thank you.
Yes, I think today we have a very successful hangout session, even though with some technical problem, I have to run in a 2-screen. But thank you so much, everyone, for your insight and then your expertise in the vaccine for the MOOC Vaccinology. And maybe Fred, if you would like to conclude the session for today.
Yeah, rapidly. Unfortunately, there was questions for Dr. Guido Brandy, who couldn't reach us. I don't know.
Yeah, we have some. There's some technology problem.
Yeah, that was interesting. I think that it's a short session, but it's interesting that we can discuss together. And
oh, hello.
Interesting. It would be also interesting if for the next sessions, because they might be able to do that, the students might participate also, because they can follow us on the YouTube. But then they can also, I suppose, they can also click somewhere to participate and ask a question directly to the forum.
Oh,
that also we should push
I think we got Dr. Grandi online.
Yes,
finally.
I can see him.
Hello.
Hi, how you doing?
Yes, how are you doing?
Actually, I was attending the session, the discussion about the RSV and HPV, which I found very interesting, by the way.
Thank you. Great. Oh.
I don't know. I understand that it's too late, but if you have any specific question that I
No,
can...
maybe
Yeah.
GB, you can ask Guido the question of the cost of vaccine production.
I actually left the question with you, Fred, but I think...
yeah, no, I can read it.
Oh, okay, great. Thank you, Fred.
How are you doing, Guido?
Very well.
Happy to see you there. So there was a question on the cost of vaccine production and antigen discovery. The people who put this question ask, I want to know from whom depends the low cost of vaccine production, as the future of vaccine will cost surely more expensive. And how can new technology in antigen discovery could help to lower the cost of vaccines? So you have this experience, Guido, of a full program of antigen discovery. Do you know about the cost? How this program was able to lower the cost or not?
Well, again, is a long question. I mean, to answer, I mean, by the way, the costs obviously are not dictated by the production costs, are mostly dictated by the type of vaccine that has to be produced and how complicated is the process. That is, first of all, you have to think about, you know. So if the process is very complicated, there are many components of the vaccine, obviously the costs are going to increase exponentially. So that is one part of the cost, which is given by really the production cost. And that can only be reduced by simplifying the formulation and the vaccine. And obviously, there are a number of ways that you can do it. Apart from trying to consider in life of attenuated vaccine, obviously there are people working on other approaches to try to simplify the process. We, for instance, are working on the vesicle production, and there are vaccines which are based on bacterial outer member vesicles, and these are very cheap to produce. They can be engineered, and there are already vaccines out there which are based on the vesicle. I'm just thinking of the meningococcus. The vaccine are in phase 2, phase 3 trials for instance, for Shigella or other type of bacteria. So that would be obviously a way to reduce the production cost. Obviously, the other side of the coin is, you know, how the costs are defined by usually by the company, and which obviously they have to reach at least the break even, and they also have to eventually try to make money out of it, and that is a part of the cost that obviously that can be reduced. And I'm sure that the programs, the national programs and support from the national from different countries that can obviously influence and affect this part of the cost, which is basically based on the time that is needed to reach the break even of the cost, and eventually how much you can recover and gain from the vaccine. So I don't know if I have addressed the question sufficiently well, but again, to summarize, the two ways to approach the cost: one, to try to simplify the vaccine formulation and find new ways to make the vaccine simpler, and that is a question of the antigen discovery and developing new type of vaccine. This is one side. On the other side is obviously the cost which are associated from obviously a more economical part and political part, and that is should be addressed on a case-by-case basis by the companies, by the countries.
Yeah, but are you able to reduce the research time by using these new technologies?
Yeah. Surely, I think that's for sure. That's the new antigen and vaccine discovery program are basically devoted to the reduction of the research time, and that is something that has been already achieved. The problem is that most of the costs are not deriving from the research cost, but most of the costs are associated with the development and the clinical trials. So even if you reduce the cost of research, which is important, and you shorten the time to reach to a formulation, then the big part of the cost still remain, which is the development and the clinical trials.
Can I just make
Please.
Just make a comment. What you said is exactly right. Ooh, I'm getting a lot of feedback here. Over the last few years, we've seen the amount of time and the amount of money which is required for the preclinical development actually go down significantly, because we're able to better identify immunological targets, because it's faster and easier to make reagents to test the immunogenicity, and because we have a better idea of what we're doing in a lot of ways. But the big costs with vaccines come in building production facilities, putting together a compliance team so that you meet all of the regulatory requirements and marketing requirements. And one of the things which makes vaccines very different from other medicines is that they're a high volume, low profit kind of product. So to build a factory, to build a production line, and to build a regulatory and marketing team to actually sell your vaccine and make sure that it's safe and meet all of the requirements, that costs exactly the same whether you're selling 250,000 doses or 25 million doses. And so I think in a lot of ways, that's the biggest obstacle to new vaccines, is being able to have a product which is desirable enough and widely attractive enough to public health services and to customers, that you can come over that hump and say, okay, we're going to invest 400 million upfront to make this happen, in the expectation that we'll make the money back in the past. And there's a phrase which has been around for a long time called the valley of death, which is where vaccines which come through R&D in academic institutes and in small biotechs, they look very promising, and then you get to the point of how do you raise the funding to actually make the vaccine available to the people who need it. And that gap between having a vaccine and having the funding to make it available, that's the so-called valley of death. Now, it's not impossible. With Menafrivac, the meningitis A vaccine, or meningococcal A vaccine, organizations like Gavi and the Gates stepped up to make that initial funding jump possible. But not every vaccine has a sugar daddy who's prepared to fund it like that. So I think this is going to be a big issue over the next few years as we have new vaccines coming to the end of their preclinical development. There's a lot of competition between companies and between individual products. And so there's also a lot of talk in the background about, can we actually make a better model for funding vaccine development? Because most people agree that it's a public good. And we can't necessarily rely on market forces to provide the money to bring those vaccines to the people who need them.
Absolutely. Thank you. Absolutely.
Yes, thank you. I think we spent quite a bit of time, of your valuable time. Thank you so much. I really appreciate your participation in this MOOC Vaccinology. And we have participants from all over the world that watching this, and they really thankful for all your expertise today. And so maybe we'll just end our hangout session today, and thank you everyone, and hope to see you all in March for the vaccinology course in Paris.
Absolutely.
Okay,
Thank you very much.
Thank you.
Thank you for organizing this.
Bye-bye.
Bye.
Bye.
Thank you. Bye.
Bye. See you. Thank you.
Bye.